Good afternoon. Today I would like to introduce you the next pharmacology lecture, Drugs Acting on Cardiovascular System, Part 2. Lecture plan: Anti-anginal and other anti-ischemic drugs, antihypertensive drugs. Let's start from anti-anginal and other anti-ischemic drugs. In here you can see angina pain or stenocardia pain, typical pain regions. Pressure, fullness, squeezing, or pain in the center of the chest. Can also feel discomfort in the neck, jaw, shoulders, back, or arms. Atherosclerotic process. Deposition of lipids in vessel wall. When plaque, fatty deposits, clogs arteries, that's called atherosclerosis. These deposits are made up of cholesterol, fatty substances, cellular waste products, calcium, and fibrin, a clotting material in the blood. As plaque builds up, the wall of the blood vessel thickens. This narrows the channel within the artery, which reduces blood flow. That, in turn, lessens the amount of oxygen and other nutrients reaching the body. In here you can see some pictures connected with coronary artery disease. Types of angina. First, stable angina, angina pectoris. Second, unstable angina. Third, variant Prince-Metal angina. Fourth, microvascular angina. Let's start from the first one, angina pectoris, stable angina. Angina pectoris is the medicinal term for chest pain or discomfort due to coronary heart disease. It occurs when the heart muscle doesn't get as much blood as it needs. This usually happens because one or more of the heart's arteries is narrowed or blocked, also called ischemia. Angina often occurs when the heart muscle itself needs more blood than it's getting, for example, during times of physical activity or strong emotions. Severely narrowed arteries may allow enough blood to reach the heart when the demand for oxygen is low, such as when you are sitting. But with physical exertion, like walking up a hill or climbing stairs, the heart works harder and needs more oxygen. Second, unstable angina. Unstable angina, or sometimes referred to as acute coronary syndrome, causes unexpected chest pain and usually occurs while resting. The most common cause is reduced blood flow to the heart muscle because the coronary arteries are narrowed by fatty buildups, atherosclerosis, which can rupture, causing injury to the coronary blood vessel, resulting in blood clotting, which blocks the blood flow to the heart muscle. Unstable angina should be treated as an emergency. If you have new, worsening, or persistent chest discomfort, you need to go to the ER. You could be having a heart attack, which puts you at increased risk for severe cardiac arrhythmias or cardiac arrest, which could lead to sudden death. Causes of unstable angina. Blood clots that block an artery partially or totally are what causes unstable angina. Blood clots may form, partially dissolve, and later form again, and angina can occur each time a clot blocks blood flow in an artery. Third variant, Prince-Metal angina. Variant angina and less commonly Prince-Metal angina, vasospastic angina, angina inversa, coronary vessel spasm, or coronary artery vasospasm is a syndrome typically consisting of angina pain, commonly occurs in individuals at rest or even asleep, and is caused by vasospasm, a narrowing of the coronary arteries due to contraction of the heart's smooth muscle tissue in the vessel walls. In comparison, stable angina is due to the permanent occlusion of these vessels by atherosclerosis. The coronary arteries can spasm as a result of exposure to cold weather, stress, drugs that constrict or dilate blood vessels, smoking, use of cocaine. And fourth, microvascular angina. This type of angina or chest pain may be a symptom of coronary microvascular disease. Coronary microvascular disease is a heart disease that affects the heart's smallest coronary artery blood vessels. Causes of microvascular angina. Spasms within the walls of these very small arterial blood vessels causes reduced blood flow to the heart muscle, leading to a type of chest pain referred to as microvascular angina. Symptoms of microvascular angina. Angina that occurs in coronary microvascular disease may differ from the typical angina that occurs in heart disease in that the chest pain usually lasts longer than 10 minutes and it can last longer than 30 minutes. The pain or discomfort may be more severe and last longer than other types of angina, may occur with shortness of breath, sleep problems, fatigue, and lack of energy, often is first noticed during routine daily activities and times of mental stress. In here you can see diagrammatic representation of coronary artery caliber changes in classical and variant angina. In classical angina, the coronary obstruction is fixed, blood flow fails to increase during increased demand, despite local factors mediated dilatation of resistant vessels, and ischemic pain is felt. Due to inadequacy of ischemic left ventricle, the end diastolic left ventricular pressure rises and produces subendocardial crunch during diastole. Blood flow to the subendocardial region occurs only during diastole and aggravates the ischemia in this region. Thus, a form of acutely developing and rapidly reversible left ventricular failure results, which is relieved by taking rest and reducing the myocardial workload. Drugs that are useful primarily reduce cardiac work, directly by acting on heart, or indirectly by reducing preload, hence end diastolic pressure, and afterload. They may also cause favorable redistribution of blood flow to the ischemic areas. In variant angina, attacks occur at rest or during sleep and are unpredictable. They are due to recurrent localized, occasionally diffuse coronary vasospasm, which may be superimposed on arteriosclerotic coronary artery disease. Abnormally reactive and hypertrophied segments in the coronary arteries have been demonstrated. Drugs are aimed at preventing and relieving the coronary vasospasm. Classification of anti-anginal drugs. First group is nitrates. They are subdivided into short-acting, for example, glyceryl trinitrate or nitroglycerin, and long-acting, isosorbate dinitrate, isosorbate mononitrate, erythritol tetranitrate, pentaerythritol tetranitrate. Second, beta blockers, atenolol, metoprolol, etc. Third, calcium channel blockers, verapamil, diltiazem, nifedipine, and others. Fourth, potassium channel openers, nicorandil. And fifth, others, dipyridamole, trimetazidine, aspirin. Clinical classification of anti-anginal drugs. A. Used to abort or terminate attack, nitroglycerin and isosorbate dinitrate. B. Used for chronic prophylaxis, all others. Let's start from nitrates, glyceryl trinitrate. Preload reduction, peripheral pooling of blood, decreased venous return, preload reduction. Afterload reduction. Nitrates also produce some arteriolar dilatation, slightly decreased total peripheral resistance or afterload on the heart. Redistribution of coronary flow. In the arterial tree, nitrates preferentially relax bigger conducting, angiographically visible, coronary arteries than arterioles or resistance vessels. Nitrates are mostly prodrugs, acting through forming thioethers that is transformed into nitric oxide. Mechanism of action. The organic nitrate agents are prodrugs that are sources of nitric oxide. Nitric oxide activates the soluble isoform of guanylyl cyclase, thereby increasing intracellular levels of cGMP. In turn, cGMP promotes dephosphorylation of the myosin light chain and the reduction of cytosolic calcium and leads to the relaxation of smooth muscle cells in a broad range of tissues. And in here you can see mechanism of vascular smooth muscle relaxant action of nitrodilators. Doses, drug forms, ways of administration, and durations of action of some nitrates. For example, nitroglycerin sublingual, isosorbate dinitrate sublingual, amyl nitrite, inhalant. These are short-acting and long-acting. Nitroglycerin oral sustained action, nitroglycerin 2% ointment transdermal, nitroglycerin slow-release buccal, nitroglycerin slow-release patch transdermal, isosorbide dinitrate sublingual, oral, chewable oral, and isosorbide mononitrate oral. Their doses and durations of action. Isosorbides and other nitrates. Nitrosorbide, isomac, nitrosorbide inhalation, isodinite, nitrosorbide intravenous, isosorbide mononitrate, Cardix, Cardicate, Cardonide, Cardiogard SR, Isomac retard. These are the trade names. Sustac forte and Sustac mite, and the composition of them. Also nitrongum or nitrong ointment, trinitrong capsules, and nitroderm TTS, transdermal therapeutic system. One more representative is molsidomine. Trade names Corvasal, Corvatone, Molsidain, Molsidolat. Molsidomine is an orally active, long-acting vasodilating drug used to treat angina pectoris. Molsidomine is metabolized in liver to the active metabolite lincidomine. Lincidomine is an unstable compound that releases nitric oxide. Molsidomine tablets 0.002, 0.004, and 0.008 grams. And here you can see the picture of it. Next group, calcium channel blockers. Mechanism of action. Calcium channel blockers inhibit the movement of calcium ions through calcium channels of L type. They affect cardiomyocytes, reduce myocardial contractility, cells of the conduction system of the heart, suppress the formation and conduction of electrical impulses, smooth muscle cells of the vessels, reduce the tone of coronary and peripheral vessels. Drugs. Amlodipine, clevidipine, which is approved only for use in hypertensive emergencies, diltiazem, felodipine, isradipine, nicardipine, nifedipine, nosodipine, verapamil. Calcium channels classification. A calcium channel is an ion channel which shows selective permeability to calcium ions. It is sometimes synonymous with voltage-gated calcium channel, although there are also ligand-gated calcium channels. You can see in here the types of calcium channels: L, PQ, N, R, T, localization, selective antagonist, and function. Voltage-sensitive calcium channels: L-type, long-lasting current, T-type, transient current, and N-type, neuronal. You can see in here conductance, activation threshold, inactivation rate, location and function, and blocker of these channels: L-type, T-type, and N-type. And in here you can see comparative properties of representative calcium channel blockers: verapamil, nifedipine, and diltiazem. Their channel blocking potency, frequency dependence of channel blockade, channel recovery rate, cardiac effects in vivo at usual clinical doses, for example, heart rate, AV conduction velocity, contractility, output, vascular smooth muscle relaxation, and their clinical use in different cardiac pathologies. Classification of calcium channel blockers. Phenylalkylamine derivatives, first generation verapamil, second generation galapamil, benzodiazepine derivatives, first generation diltiazem, phenylalkylamine and benzimidazole derivatives, miberfadil, and dihydropyridine derivatives, first generation nifedipine, second generation nicardipine, felodipine, benidipine, isardipine, third generation amlodipine, lazidipine, lercanidipine. Next group, beta-adrenoreceptor blockers. Mechanism of action. decrease action of catecholamines, increase refractory period of heart muscle by beta-adrenergic receptor inhibition, selective beta-1 or non-selective beta-1 plus beta-2 receptors blockers. Classification: non-selective without inner sympathomimetic activity, propranolol. Non-selective with inner sympathomimetic activity, oxprenolol. Selective without inner sympathomimetic activity, atenolol. And selective with inner sympathomimetic activity, acebutolol. More detailed classification of non-selective beta-adrenergic receptor blockers without inner sympathomimetic activity, propranolol, trade names anapreline, obsidan, nadolol, and timolol. With inner sympathomimetic activity, oxprenolol, pindolol, alprenolol, penbutolol, carteolol, bopindolol. And selective ones without inner sympathomimetic activity, atenolol, metoprolol, bisoprolol, betaxolol, nebivolol, bevantolol, esmolol, and with inner sympathomimetic activity, acebutolol. The next part of our lecture is antihypertensive drugs. Hypertonic disease, common illness of unidentified etiology, the main manifestations of which are elevated blood pressure, often combined with regional disturbances of the vascular tone, in the absence of the connection with the primary organic damage of any organs or systems, characterized by the stage of development of symptoms. In more than 90% of cases, hypertension is idiopathic, primary, essential, and then it is called hypertension. In 5–10% of cases, hypertension has an established cause, symptomatic hypertonic disease. According to the recommendations of the Joint Committee of Experts of World Health Organization and the International Association for the Study of Arterial Hypertension in 1999, the parameters of normal blood pressure are divided into the following categories: optimal blood pressure, systolic blood pressure less than 120, diastolic blood pressure less than 80, normal, systolic blood pressure less than 130, diastolic blood pressure less than 85, and high normal blood pressure, systolic blood pressure 130 to 139, diastolic blood pressure 85 to 89. Under hypertensive disease should be understood as an increase in systolic blood pressure more than 140 or diastolic more than 90. Stages of hypertension. First stage. There are no objective manifestations of organic changes in vital organs. Second stage. There are objective manifestations of organic changes of vital organs, left ventricular hypertrophy, generalized or focal narrowing of the arteries of the retina, proteinuria or hypercreatinemia, primarily not related to kidney diseases. Third stage, complications arise hypertonic disease, myocardial infarction, chronic heart failure, ischemic and hemorrhagic stroke, renal insufficiency. And in here you can see the table which summarizes blood pressure evaluation. Hypertension is common in developed countries with more people living in big cities compared with village populations. With age, the frequency of occurrence of hypertonic disease increases in persons over 40 years old, reaches 20–25% with a relatively same distribution among men and women. Causes of hypertonic disease are not fully understood. Among the factors that cause development of hypertonic disease are emotional stress, hereditary constitutional features, profession factors, peculiarities of nutrition, excessive consumption of cooking salt, saturated fats, magnesium deficiency, age reorganization of the encephalous hypothalamic structures of the brain during the period of climax, skull trauma, intoxication, hypodynamia. The trigger mechanism of pathogenesis in hypertonic disease is hyperactivity of the nerve centers of regulation of blood pressure. The increased activity of these centers is expressed in the intensification of pressure influences, which are carried out through increased activity of the sympathoadrenal system, increased production of renal pressure substances by the inclusion of the renin-angiotensin mechanism, increased production of prostaglandin F2 alpha and cyclic nucleotides, increased vasopressin secretion. The mechanisms of development of hypertension are also increased peripheral resistance due to spasm of the peripheral vessels, an increase in the minute volume of the heart due to the intensification of its work, or the growth of intravascular volume of fluid due to delayed sodium. Clinical picture depends on which of the links in the pathogenesis of hypertonic disease prevails. With hyperadrenergic variant, liability of blood pressure, increase of pumping and minute volume of blood is observed. Clinical manifestations: palpitations, unpleasant sensations in the area of the heart, a feeling of throbbing in the head, reddening of the face, sweating, cold, anxiety. The level of renin in the blood plasma is usually normal. With angiotensin-dependent variants, there is a stable high diastolic blood pressure, tendency to arteriospasm, accompanied by changes in the vessels of the eye bottom, developing myocardial infarctions and cerebral stroke. Often, a high level of renin in the blood plasma is determined. At sodium-dependent version, there is a connection with the use of a large amount of fluid and salt, increased volume of extracellular fluid. Clinical manifestations: swelling of the eyelids, puffiness of the face, numbness of fingers, paresthesia. Myocardial infarction and stroke occur rarely. Often, a low level of renin in the blood plasma is determined. In a hypertensive crisis, a sudden and pronounced increase in blood pressure, accompanied by severe clinical symptoms and requiring immediate reduction, is manifested. Diagnostics. The purpose of the examination of patients with hypertensive disease is the confirmation of stability of blood pressure increase, the exclusion of the symptomatic form of arterial hypertension, the assessment of the presence of damage to the target organs, the establishment of risk factors for cardiovascular diseases. The obligatory researches include urine analysis, a general blood test, a biochemical blood test, potassium, sodium, creatinine, glucose, total cholesterol, and high-density lipoprotein, ECG, chest X-ray examination, eye bottom examination. The task in treating patients with hypertension is to prevent the progression of the disease and the development of complications. Pharmacotherapy should provide reduction of systolic blood pressure to 140-130 and diastolic to 90-85. Further reduction of blood pressure is inappropriate. In patients with borderline hypertonic disease, pharmacotherapy should be preceded by non-medicated methods of treatment, limiting the consumption of kitchen salt, alcohol, reduction of excess body weight, increase in physical activity, sufficient consumption of potassium, calcium, and magnesium, refusal of tobacco smoking, reduce the amount of saturated fat and cholesterol in the diet. Conducting pharmacotherapy hypertension is an important condition for ensuring effective control of blood pressure overnight, 24 hours. The optimal blood pressure should be maintained in the morning when the risk of stroke and myocardial infarction is the highest. In this regard, preference is given to drugs with prolonged action, the effect of which develops and ends gradually. An ideal condition is hypotensive therapy under the control of daily blood pressure monitoring, which has a significant advantage over one-time or office blood pressure measurements. Treatment of hypertension begins with the minimum doses of a particular drug. For long-term treatment, drugs with a 24-hour effect with a single dose per day are preferred. Optimal combinations of drugs to achieve maximum antihypertensive effect and minimize their side effects. With insufficient effectiveness of the treatment, should be provided the increase of the dose of the drug or addition of second drug. The choice of antihypertensive drugs and the tactics of pharmacotherapy are determined by the following factors: the stage of hypertonic disease, damage to the target organs, concomitant diseases. In this case, uncomplicated hypertension, in the absence of established indicators for the administration of other antihypertensive drugs, give preference to beta blockers, ACE inhibitors, calcium channel blockers, and diuretics. In the presence of prescribed indications for the treatment of hypertension, drugs from the main modern classes of antihypertensive drugs can be used. There is a strong proof of the need for two or more drugs to achieve adequate blood pressure monitoring. Effective combinations are beta-adrenergic receptor blocker plus diuretics, diuretics plus ACE inhibitor or angiotensin II receptor antagonist, beta-adrenergic receptor blocker, calcium channel blocker with ACE inhibitor, beta-adrenergic blocker with alpha-adrenergic blocker. At urgent conditions of treatment, it is possible to start with oral administration of drugs with a fast onset, for example, loop diuretics, blockers of beta-adrenergic receptors, ACE inhibitors, calcium channel blockers. After stabilization of the state, prescribed a long-acting drug. Antihypertensive or hypotensive drugs are substances of different structure, therefore they are more often classified according to the mechanism of action, but not according to the chemical structure. Hypotensive agents reduce blood pressure by various mechanisms. The pressure in any pipeline system, which can be conventionally compared to the CVS, depends on the volume of fluid in it, the width of the lumen of the tubes, vessels, and the strength of the pump, the heart. Hypotensive drugs reduce the volume of circulating blood, increase the width of the vascular lumen, and thus reduce overall peripheral resistance. They also reduce cardiac contractility and cardiac output. And in here you can see anatomic sites of blood pressure control. Resistance, arterioles, capacitance, venules, pump output, heart, volume, kidneys. Main antihypertensive groups of drugs. In here you can see diuretics, beta-adrenergic receptor blockers, alpha-1 selective adrenergic receptor blockers, centrally acting sympatholytic drugs, postganglionic sympathetic nerve terminal blockers, ganglion blocking agents, vasodilators used in hypertension, calcium channel blockers, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, direct renin inhibitors, and agonists of imidazoline receptors. The same groups can be classified according to the first line and the second line. Antihypertensive drugs of the main group, first line. Those groups of drugs which we discussed before, today we will quickly revise. New ones we will discuss in more details. First, diuretics, we talked about them in details in lecture 10. Second, beta-adrenal blockers, we talked about them in lecture 5, but we will anyway stop on them a little today. Third, calcium channel blockers, we will also discuss them in more details today. Fourth, alpha-adrenal blockers, we will also discuss them today in little more details, but we also discuss them in lecture 5. Angiotensin converting enzyme inhibitors, we discussed them in the previous lecture 11, and blockers of angiotensin II receptors. We also discussed them in lecture 11. And secondary drugs, second line. First, agonists of central alpha-2 adrenergic receptors. We discussed them in lecture 5, but we will anyway stop on them a little today. Second, sympatholytics, reserpine, raunatin, octadine. We also discussed them in lecture 5, but we will stop on them today. Vasodilators, we will stop on them in details today. Fourth, agonists of imidazoline I1 receptors. We will stop on them today in details. Fifth, inhibitors of renin. We talked about them in previous lecture 11. Plus ganglion blocking agents. We talked about them in lecture 4, but we will anyway stop on them today. So the first group is diuretics. We met with them in lecture 10, so I will not stop on them in very big details. I will stop on this slide for a few seconds, also on this one. But I would like to point your attention on those diuretics which are usually used in cases of hypertension. These are thiazides, specifically hydrochlorothiazide, chlorthalidone, indapamide, and trichlormethiazide, loop diuretics, specifically furosemide, torsemide, and potassium-sparing diuretics, amiloride and spironolactone. Also to remind you, thiazides and related diuretics, drug names, total daily oral doses, and frequency of daily administration. Furosemide and etacrinic acid, dosage of loop diuretics, drug names, and total daily oral doses, and spironolactone amiloride potassium-sparing diuretics, their names and combinations. Next group is beta-adrenergic receptor blockers. We met with them in lecture 5, but anyway, I will stop on them today as they are very important in this case. So in here you can see different drug names of beta-adrenergic blockers. Next slide, very important mechanism of action once again. So mechanism of action, decrease action of catecholamines by beta-adrenergic receptors inhibition, selective beta-1 or non-selective beta-1 plus beta-2 receptors blockers. Non-selective without inner sympathomimetic activity propranolol, non-selective with inner sympathomimetic activity oxprenolol, selective without inner sympathomimetic activity atenolol, and selective with inner sympathomimetic activity acebutolol. And the same slides which were already in this lecture in the beginning, non-selective beta blockers and selective beta blockers. Side effects of beta blockers: cardiac, pronounced sinus bradycardia, violations of atrioventricular conduction, decreased systolic function of the left ventricle. Second, bronchial obstruction, especially in patients with altered bronchial reactivity. Third, disturbance from the central nervous system, fatigue, headache, loss of attention, dizziness, sleep disturbance, state of excitement, depression, dysphoria. Fourth, deterioration of lipid metabolism, accumulation of low and very low density lipoprotein, triglycerides, lowering of high density lipoprotein, increased blood serum atherogenic properties, especially in conditions of increased dietary intake of sodium chloride. Fifth, gastrointestinal, nausea, vomiting, flatulence, stinging, diarrhea, and feeling of heaviness in the epigastric region. Sixth, increased risk of insulin-induced hypoglycemia, masking of symptoms of hypoglycemia. Seventh, spasm of the vessels of the lower extremities. Eighth, increased levels of uric acid in the blood. Ninth, increased uterine tone and bradycardia in the fetus during pregnancy. 10th, allergic reactions. 11th, sexual dysfunction, especially when taking lipophilic drugs. 12th, hepatotoxicity for preparations with properties of alpha blockers. 13, oculocutaneous syndrome. 14, in rare cases, Tylenol can cause drowsiness, weight gain, decreased lacrimal fluid secretion, alopecia, and increased symptoms of psoriasis with the use of atenolol. Contraindications of beta blockers. According to the current recommendations, absolute contraindications to the administration of beta blockers are severe bradycardia with clinical manifestations, atrioventricular blockade of high degree, syndrome of weakness of the sinus node, cardiogenic shock, severe lesions of peripheral arteries, hypotension with clinical symptoms, bronchial asthma, and COPD disease with bronchoconstriction, as well as the simultaneous use by the patient of bronchodilators and individual hypersensitivity. Relative contraindications are COPD without bronchial obstruction, diabetes mellitus, especially with the use of insulin patients, non-severe lesions of the peripheral arteries, asymptomatic dysfunction of the sinus node, AV blockade of the first degree, dyslipidemia, and depressive states. In such cases, beta blockers should be used with caution. Third group is calcium channel blockers. We talked about them in this lecture already, so further 3 slides I will simply show to you for a few seconds. And I will stop on this slide. Selectivity of calcium channel blockers on the heart and peripheral vessels is the basis of this classification. Cardioselective or heart rate lowering calcium channel blockers, derivatives of verapamil and diltiazem, which have a negative ino, chrono, and dromotropic effect and may decrease the contractile capacity of the myocardium, decrease the heart rate, and slow down the atrial fibrillation conductance. Next is vasoselective or vasodilating calcium channel blockers, derivatives of nifedipine, have no clinically significant effect on sinus node function and atrial ventricular conductivity. Classification of calcium channel blockers by duration of action. Short action 6-8 hours. It is necessary to take 3-4 times a day. Verapamil tablets 80 mg, diltiazem, nifedipine, nicardipine, etc. Next, with an average duration of action from 8 to 18 hours, it is necessary to take 2 times a day. Isradipine, felodipine, as an example tablets 5 mg, etc. And next, prolonged action should be taken once a day. Retired forms of verapamil, diltiazem, isradipine, nifedipine, and felodipine, and with the effect of 24 to 36 hours. Amlodipine tablets 5 mg. Indications for use of calcium channel blockers. First, dihydropyridine, phenylalkylamine, and benzodiazepine derivatives are used for the treatment of hypertension as monotherapy as well as in combination therapy. Second, dihydropyridine calcium channel blockers, especially nifedipine, are used to treat hypertension during pregnancy and have a tocolytic effect. Dihydropyridine derivatives can be used to treat Raynaud disease, and they remain the main drugs for the treatment of angina pectoris. Third, phenylalkylamine and benzodiazepine calcium antagonists are effective in the treatment of supraventricular rhythm disorders, with the exception of Wolff-Parkinson-White syndrome and bradyarrhythmia. Fourth, diphenylpiperazine derivatives are used for disorders of the cerebral circulation, ischemic stroke, and hemorrhagic stroke. And below you can see the description of Raynaud's disease and Wolff-Parkinson-White syndrome. Side effects of calcium channel blockers. Side effects, depending on the group, are edemas of legs and in the area of elbows, most often with the use of dihydropyridine derivatives, but relatively often observed with the use of other calcium antagonists. Also, headache, dizziness, blood flushes to the face. At the beginning of treatment with the use of calcium channel blockers, severe hypotension may occur. When using dihydropyridine drugs, tachycardia can be observed, and when using non-dihydropyridine drugs, bradycardia. Common side effects for all calcium channel blockers from the cardiovascular system are the onset of atrioventricular blockade and other conduction abnormalities and the development or increased severity of heart failure. Rare side effect observed with the use of dihydropyridine calcium antagonists is gingival hyperplasia. When using verapamil, a frequent side effect, up to 6.3%, is constipation. Other side effects, increased activity of aminotransferases, impotence, leukopenia, thrombocytopenia, diarrhea, skin allergic reactions, are extremely rare. The increased risk of developing breast cancer with prolonged use of calcium channel blockers, reported in clinical trials, has not been confirmed in further studies. And on this slide, you can see comparative properties of representative calcium channel blockers, and with the same slide we met before in today's lecture. Fourth group, alpha adrenoblockers. Mechanism of action. Blockage of alpha adrenal receptors, which leads to the inhibition of the action of alpha adrenal-stimulating hormones, catecholamines, on the blood vessels. Selective alpha-1 blockers block selectively postsynaptic alpha-1 adrenergic receptors. Non-selective alpha-adrenergic blockers act on both postsynaptic alpha-1 adrenergic receptors and presynaptic alpha-2 adrenergic receptors. The consequence of the actions of the group's drugs is the dilation of peripheral vessels, more arterioles and precapillaries, reduction of peripheral vascular resistance, and lowering of arterial pressure. As a result of the action of alpha adrenal blockers, the tone of the vessels of the lungs decreases, the volume of the contractive and the minute volume of blood increases, the blood supply to the muscles, skin, and mucous membranes improves, but it is also accompanied by the appearance of reflex tachycardia and the appearance of peripheral edema. With prolonged use of the drugs of this group, mainly selective alpha-1 blockers, there is a decrease in low-density lipoprotein and total cholesterol. Alpha blockers also cause relaxation of the smooth muscles of the prostate and its capsules, as well as the neck of the bladder, resulting in a decrease in resistance and pressure in the urinary tract. As a result, these drugs are used in hyperplasia of the prostate gland. Classification of alpha adrenal blockers. Once again, we stopped on these drugs in lecture 5, but I would like to remind you this information. Non-selective alpha blockers: phentolamine, tropodephan, nisergolin, proroxan, butyroxan, phenoxybenzamine, and indoramine. And selective alpha-1 adrenergic blockers: prazosin, tablets 1 mg, doxazosine, terazosine, alfuzosin, silodosin, tamsulosin, and urapidil. Indications of alpha adrenal blockers. Alpha blockers were initially used to treat arterial hypertension, including for the treatment and diagnosis of pheochromocytomas. However, non-selective drugs, in particular phentolamine and tropodephan, are now practically withdrawn from use due to their low efficiency and short period of action, and therefore are used exclusively for the diagnosis of pheochromocytomas. Drugs from the group of selective alpha-1 adrenal blockers, prazosin, doxazosine, terazosine, are used to treat arterial hypertension. Urapidil is used in this group, preferably in the cases of resistant hypertension for the treatment. Selective alpha-1 blockers, due to their effect on the smooth muscle of the prostate and its capsules, as well as the bladder cervix, are now used to treat benign prostatic hyperplasia and other diseases of the prostate gland that are accompanied by the urinary retention, with alfuzosin and terazosine have been developed as highly selective drugs for the treatment of urinary retention in men. Non-selective adrenal blockers, phentolamine and tropodephan, are used to treat Raynaud's disease, obliterative endarteritis, early stages of gangrene due to obliterating atherosclerosis of the lower extremities vessels, acrocyanosis, trophic ulcers of the lower extremities, treatment of bed sores and frostbite, and also for the prevention of skin necrosis under the skin of norepinephrine. Another non-selective alpha blocker, proroxan, is used in vegetative and neurosis-like disorders of the nervous system, including sympathoadrenal crisis, allergic dermatitis and skin itching, Meniere's disease and Marine disease, and can also be used to treat withdrawal syndrome with drug and alcohol abuse. And below you can see the description about pheochromocytoma. Side effects of alpha adrenal blockers. With the use of alpha blockers, the most common side effects are orthostatic arterial hypotension, which occurs when taking the drug in a standing position, tachycardia, shortness of breath, edema of the lower extremities. These side effects are more likely to occur with the use of non-selective alpha-adrenergic blockers and selective alpha-1 adrenal blockers initially developed for the treatment of arterial hypertension, prazosin, doxazosine, terazosine. With the use of highly selective alfuzosin and tamsulosin, these side effects are much less common. Other side effects of the drugs of the group are nasal congestion, skin rash, itchy skin, headache, dizziness, diarrhea, priapism. Contraindications of alpha adrenal blockers: increased sensitivity to the drugs, marked arterial hypotension, severe heart failure, marked cerebral vascular atherosclerosis, ischemic heart disease, especially with angina pectoris, pregnancy, breastfeeding. The fifth group is angiotensin-converting enzyme inhibitors. In here you can see renin-angiotensin system regulation of blood pressure, the same slide you saw in the previous lecture. The drugs are benazepril, captopril, enalapril, fosinopril, lisinopril, moexipril, perindopril, quinapril, ramipril, randolapril. The mechanism of action and classification we discussed in the previous lecture. And also comparative features of some ACE inhibitors was also presented in previous lecture. Also quick revision of indications of ACE inhibitors. You can see in here hypertension, coronary artery disease, heart failure, diabetes, certain chronic kidney diseases, myocardial infarction, scleroderma, migraines, side effects of them, dry cough, hyperkalemia, fatigue, dizziness, headaches, loss of taste. The next group, angiotensin II receptors blockers. We also discussed them in the previous lecture. You can see the drug examples in here: candesartan, eprosartan, irbesartan, losartan, olmesartan, telmisartan, and valsartan. Mechanism of action of them, let's revise this. The mechanism of action of angiotensin II receptor inhibitors is to block the binding of angiotensin II to angiotensin II receptors, leading to vasodilation, lowering the release of aldosterone, and decreasing sodium reabsorption in the kidneys. All these effects in a total amount result in antihypertensive effect. The drugs of the group have a different affinity for angiotensin II receptors, through which the effect of angiotensin II is realized. With prolonged use of sartans, there is also a recurrence of left ventricular hypertrophy. The drugs of the group also have nephroprotective properties, reduce insulin resistance and proteinuria in diabetes mellitus. Sartans have no negative influence on lipid metabolism. In addition, losartan and, in part, telmisartan have the ability to increase uric acid excretion, which makes it possible to apply in hypertension and concomitant nephropathy and gout. Part of the drugs of this group, for example, telmisartan and olmesartan, can prevent the proliferation of vascular smooth muscle cells, which, according to the contemporary ideas about suppressing the proliferation of vascular smooth muscle cells, as one of the pathogenetic factors in the development of atherosclerosis, sartans can be considered as drugs for reducing the risk of coronary heart disease. Prolonged treatment with the preparations of the group of sartans lead to improved collateral circulation in the brain tissue, reduction of apoptosis of the neurons, narrowing of large cerebral vessels, and thus the protection of small caliber vessels that are most likely to break, which give the ability to prevent hemorrhagic stroke. Eprosartan has an additional mechanism of vasodilating activity. It blocks the presynaptic angiotensin II receptors in the sympathetic nervous system and inhibits the release of noradrenaline from the endings of sympathetic nerve fibers and thereby reduces the stimulation of the adrenoreceptors of smooth muscle vessels. Preparations of the group losartan-valsartan have a positive effect on the erectile function in men. According to studies, the drugs of the group olmesartan-losartan can inhibit the development of pancreatic cancer and other tumors. In addition, sartans do not affect the metabolism of a strong vasodilator bradykinin and substance P, which leads to a decrease in side effects associated with the accumulation of bradykinin. Indications for use. Angiotensin II receptor antagonists are used to treat hypertension as monotherapy and as the part of a complex treatment. An indication for the use of angiotensin II receptor antagonists is also chronic heart failure with systolic dysfunction of the left ventricle, especially with increased sensitivity to ACE inhibitors. Preparations of the group of sartans with a nephroprotective purpose are shown in chronic kidney diseases, including hypertension and diabetic nephropathy and microalbuminuria. Sartans are indicated in the presence of recurrent transient ischemic attacks and a transmitted ischemic stroke with a neuroprotective effect. Preparations of the angiotensin II receptor antagonist group are also indicated for hyperuricemia and for prevention of arrhythmias and atrial fibrillation. Side effects. When using drugs from the group of angiotensin II receptor antagonists, headache, upper respiratory infections, dizziness, and flu-like symptoms are most commonly observed. When using sartans, dizziness, insomnia, orthostatic hypotension, especially after the first dose, pharyngitis, muscle cramps, myalgia, back pain, liver failure, kidney function disorder, skin rash, diarrhea, anemia can also occur. The frequency of side effects, especially dry cough, in the group of sartans is significantly lower than in the group of ACE inhibitors. Contraindications of angiotensin II receptor blockers. Contraindications to the use of drugs from the group of angiotensin II receptor antagonists are increased sensitivity to group drugs, pregnancy and breastfeeding, severe hepatic failure and obstructive diseases of the gallbladder, severe renal failure, hypotension. Drugs of the group are recommended to be used with caution in patients with bilateral stenosis of the renal arteries or unilateral in the case of a single functional kidney in connection with the high probability of development of severe hypotension and renal failure. In the case of mitral or aortic stenosis or idiopathic subatrophic aortic stenosis, in patients with hemodialysis. Angiotensin II receptor antagonists are not recommended for use in childhood, with the exception of valsartan, which is approved for the treatment of arterial hypertension in children from 6 years of age. Now we came to the point of additional drugs, second line, and the first group, which is agonists of central alpha-2 adrenergic receptors. In here we have clonidine and metal-dopa. Clonidine tablets 0.15 milligrams. They provide stimulation of synaptic alpha-2 adrenergic receptors of central adrenergic neurons with inhibitory effects on the vessel's motor center of the medulla oblongata as well as on vessels. The inhibition of sympathetic innervation causes a decrease in blood pressure, a decrease in heart contractions, a decrease in peripheral vascular tone of the kidneys. Clonidine reduces the activity of renin in blood plasma, which is important for antihypertensive action. Reduced excretion of sodium, calcium, and water, and the rate of glomerular filtration is inhibited. Therefore, it is advisable to take clonidine in combination with diuretics, derivatives of thiazide. Clonidine raises the resistance of the vessels of the brain and slows down the cerebral circulation. The function of the central nervous system is predominantly depressant. An analgesic, sedative, hypnotic effect is observed. The threshold of excitability of the neuron of the mesenteric formation increases and body temperature decreases. Metal-dopa is associated with its ability to pass through the blood-brain barrier, to turn into methylnoradrenaline, to stimulate postsynaptic alpha-2 adrenergic receptors of the central nervous system, which reduces the tone of the vascular center. Uses of clonidine and metal-dopa: arterial hypertension, hypertensive crisis, migraine, depressive states, alcoholism, non-anesthetic anesthesia. Side effects. After administration of clonidine, especially parenteral, there arises orthostatic arterial hypotension. In the first minutes, short-term increase in blood pressure. At the beginning of treatment, dry mouth develops as a result of inhibition of the secretion of the salivary glands. After 4 to 6 weeks, this effect is reduced and sometimes disappears. The hyposecretion of gastric juice and acid leads to constipation, especially at the beginning of treatment. With depressing effects on the central nervous system, there is the appearance of drowsiness, general weakness, fatigue, increased effects of alcohol, barbiturates, sometimes depression, sexual weakness. Clonidine may potentiate hypoglycemia, therefore it should be carefully administered to patients with diabetes mellitus. After parenteral administration, to avoid orthostatic collapse, patients should lie down for 1.5 to 2 hours. Contraindications of agonists of central alpha-2 adrenergic receptors. atherosclerosis of the vessels of the brain, reduction of cerebral blood flow, administration together with antidepressants, reduction of antihypertensive action, with hypnotics and psychotropic drugs, potentiation of central action is possible, hepatitis, liver cirrhosis, predisposition to depression, pheochromocytoma, pregnancy, Parkinsonism. Must be prescribed with caution to the elderly patients because of the danger of developing heart failure. Next group, sympatholytics, reserpine, rounatine, octadine. We also met with them in lecture 5, but anyway, let's stop shortly on them. Mechanism of action. Inhibition of the effects of stimulation of sympathetic nerves, but they do not prevent the action of exogenous adrenaline and norepinephrine. The most important thing in sympatholytic action is their effect on the cardiovascular system, namely the antihypertensive effect, for which they are used in the clinic for the treatment of hypertension. Indications. The main indication of reserpine is arterial hypertension. Reserpine is also used for nervous and psychiatric disorders caused by high blood pressure. Rounatine is prescribed primarily as an antihypertensive agent in various forms of arterial hypertension, rarely with vegetative vascular dystonia for hypertension type. Side effects: nasal congestion, sweating, general weakness, dizziness, dysfunction of the digestive canal. Side effects disappear after reducing the dose of the drug or stopping its administration. Third group is vasodilators. As an examples, pentoxifylline, apressin, diazoxide, sodium nitroprusside, magnesium sulfate, bendazole, papaverine, drotaverine, etc. Let's take few drugs as an examples. Sodium nitroprusside is used for hypertensive emergency intravenously with rapid onset. Mechanism of action: deploys nitric oxide for its antihypertensive effect. Nitric oxide works to reduce total peripheral resistance and venous return. This reduces both preload and afterload. Side effects: hypotension, methemoglobinemia, cyanide poisoning, bradyarrhythmia, palpitations, tachyarrhythmia, confusion, dizziness. Next one, hydralazine. Works as a direct-acting smooth muscle relaxant, working as a vasodilator in resistance arterioles. Decreasing total peripheral resistance and lowering blood pressure. Used to treat hypertensive disease in pregnancy. Gestational hypertension. Also like sodium nitroprusside, it may also be used in hypertensive emergencies where symptoms from hypertension are present. Side effects: headache, tachycardia, palpitations, hypotension, aching, swelling joints, flushing. Fourth group, agonists of imidazoline I1 receptors. In here we have moxonidine and rilmenidine. The I1 receptor appears to be a G-protein coupled receptor that is localized on the plasma membrane. It may be coupled to PLA2 signaling and thus prostaglandin synthesis. In addition, activation inhibits the sodium-hydrogen antiporter and enzymes of catecholamine synthesis are induced, suggesting that the I1 receptor may belong to neurocytokine receptor family, since its signaling pathways are similar to those of interleukins. It is found in the neurons of the reticular formation, the dorsomedial medulla oblongata, adrenal medulla, renal epithelium, pancreatic islets, platelets, and the prostate. They are notably not expressed in the cerebral cortex or locus coeruleus. Animal research suggests that much of the antihypertensive action of imidazoline drugs, such as clonidine and others, is mediated by the I1 receptor. In addition, I1 receptor activation is used in ophthalmology to reduce intraocular pressure. Other putative functions include promoting sodium excretion and promoting neural activity during hypoxia. Moxonidine. It dissociates between a 10% alpha-2 adrenal receptor agonist action and a 90% specific antihypertensive action resulting from its selective agonistic action at I1 imidazoline receptors, 0.2 to 0.4 milligrams daily. Moxonidine produces a pronounced reduction in peripheral vascular resistance without reflex tachycardia, accompanied by reduced plasma norepinephrine concentration and plasma renin activity. Cardiovascular responses to exercise and standing remain nearly normal, and serious or life-threatening side effects, particularly the sympathetic overactivity that can occur on sudden withdrawal of other centrally acting agents, are never observed. In addition, moxonidine behaves neutrally with respect to plasma levels of cholesterol, potassium and glucose and lipid metabolism, and renal function, and can be administered without complication to patients with asthma or certain other diseases. Comparisons between moxonidine and other well-established antihypertensive drugs such as nifedipine, atenolol, or angiotensin-converting enzyme inhibitors showed equal effectiveness in lowering blood pressure, whereas the adverse events profile always favored moxonidine. Considering its efficacy, safety, and specific effects, moxonidine meets the criteria satisfied by other currently prescribed antihypertensive drugs. The fifth group of second-line drugs is renin inhibitors. We met with it in previous lecture. So, shortly, mechanism of action: inhibit the first and rate-limiting step of the renin-angiotensin-aldosterone system, the conversion of angiotensinogen to angiotensin 1. The drug is aliskiren. This slide you saw in the previous lecture, but I will leave it for a few seconds for your revision. Side effects of renin inhibitors: angioedema, hyperkalemia, hypotension, diarrhea, headache, dizziness. Contraindications: aliskiren should not be taken alongside with ACE inhibitors or ARBs in diabetic patients due to the increased risk of stroke, hyperkalemia, and kidney complications. And on this and next slide, I prepared for you some combinations of antihypertensive drugs which are available in the market. Let me explain you the logic on one example. For example, triplyxan, 4 types. What does it mean? This drug contains perindopril and indapamide and amlodipine. What are the types? First type is triplyxan, which contains 10 milligrams of perindopril, 2.5 milligrams of indapamide, and 10 milligrams of amlodipine. Second type is perindopril 5 milligrams, indapamide 2.5, amlodipine 5. Third type is perindopril 10, indapamide 1.25, amlodipine 5. Fourth type, perindopril 5, indapamide 1.25, amlodipine 10. I will leave this slide for a few seconds for you to be able to look through all those drugs. And the next slide also. And as an additional group, in condition of hospital treatment, ganglionic blockers. Some drugs: benzohexonium, dimecolinum, pentaminum, digronium, and their specific side effect, orthostatic collapse. We met with these drugs in lecture 4. Hypertensive emergencies and urgencies may be started with rapidly acting oral hypotensive drugs, for example, nifedipine 0.01 sublingually every 30 minutes, captopril 0.025 orally every 1-2 hours, and clonidine 0.0001 or 100 micrograms every 1-2 hours orally. And parenteral, preferably IV, sodium nitroprusside, arteriovenous vasodilator from 20 to 300 micrograms minute, glyceryl trinitrate, arteriovenous vasodilator 5 to 10 micrograms minute, hydralazine directly, acting arteriolar vasodilator from 0.01 to 0.02 IM or slow IV, esmolol beta blocker 0.0005 grams kilogram bolus, followed by slow IV injection 50 to 100 micrograms kilogram minute. Phentolamine non-selective alpha-1 plus alpha-2 blocker, injected 0.005 to 0.01. It acts in 2 minutes and acts in less 5 to 15 minutes. Tachycardia and myocardial ischemia may complicate its use. Labetalol also, alpha plus beta blocker, and furosemide diuretic, 0.02 to 0.08 oral or IV. And the last part of our lecture is examples of MCQs. A patient with myocardial infarction was admitted to the cardiological department. For pain relief, it was decided to potentiate fentanyl action with a neuroleptic. Which of the following neuroleptics is the most suitable for neurolept analgesia? This is the question from CNS, but it has got connection with myocardial infarction, and I wanted to remind you that droperidol is the drug of choice in this case. A patient with coronary artery disease was admitted to the cardiological department. For stenocardia prevention, a drug from the group of beta blockers was administered. What drug is it? This is very simple MCQ. Of course, the correct answer is metoprolol. A patient suffers from stenocardia and takes isosorbide mononitrate. He was prescribed a complementary drug with disaggregating effect. What drug is it? As you remember, I told you in central nervous system that aspirin in small doses up to 100 milligrams provides anti-aggregatory effect. So it is the correct answer. After a tooth extraction, a patient felt persistent pain behind his breastbone. After sublingual intake of an anti-anginal drug, the pain behind the breastbone disappeared, but the patient complained of headache and dizziness. What drug are these properties typical for? So patient had pain, angina pain. He took sublingually some anti-anginal drug and his pain disappeared, and he felt side effects as headache and dizziness. All these hints are pointing on nitroglycerin. A patient suffering from coronary artery disease had taken a certain drug many times a day in order to arrest stenocardia attacks. Overdose of this drug finally caused intoxication. Objectively, cyanotic skin and mucous membranes, dramatic fall in the arterial pressure, tachycardia, respiration inhibition. Blood has increased concentration of methemoglobin. The drug the patient had taken relates to the following group. So, stenocardia attacks, intoxication, and all the symptoms of this intoxication are pointing on organic nitrates. Anaprylene therapy caused positive effect in the dynamic of the disease of a 44-year-old woman suffering from stenocardia. What is the main mechanism of the effect of this medicine? I hope you remember that anaprylene, it is the trade name of propranolol, and propranolol is beta-adrenergic receptor blocker. So the correct answer is A. Blockade of beta-adrenergic receptors and decrease myocardial requirements to the oxygen. A patient who had myocardial infarction was administered 75 milligrams of acetylsalicylic acid a day. What is the purpose of this administration? As I told before, and as you know from central nervous system, reduction of thrombocyte aggregation. Diuretic drug was prescribed to the patient with hypertension in the course of complex treatment. In a few days, blood pressure decreased, but signs of hypokalemia developed. What drug could cause such complications? So we are searching for diuretic. From the list, there are only 3 diuretics, B, C, and D, but B and D are potassium sparing, so the correct option is C, Lasix, and Lasix is the trade name of furosemide. A patient with second-stage hypertension has been taking one of hypotensive medications for the purpose of treatment. After a time, arterial pressure decreased, but the patient started complaining of flaccidity, sleepiness, indifference. A bit later, he felt stomach pain. He was diagnosed with ulcer. What hypotensive medication had the patient been taking? Please remember that these are the side effects of sympatholytics, and sympatholytics, in this case reserpine, are contraindicated in ulcer patients. A patient suffering from initial hypertension has been taking an antihypertensive preparation for a long time. Suddenly, he stopped taking this preparation. After this, his condition grew worse. This led to development of hypertensive crisis. This by effect can be classified as, of course, in this case, we're talking about abstinence syndrome because patient was taking a drug for a long time and suddenly he stopped and his condition grew worse and development of hypertensive crisis arose. A 66-year-old female patient got intravenous injection of magnesium sulfate solution for the purpose of elimination of hypertensive crisis. But arterial pressure didn't go down, and after repeated introduction of the same preparation, there appeared sluggishness, slow response, inhibition of consciousness, and respiration. What preparation is antagonist of magnesium sulfate and can eliminate symptoms of its overdose? Please remember as the rule that the antagonist of magnesium sulfate is calcium chloride. A patient with hypertensive crisis was admitted to the cardiological department. He was injected intravenously with an antihypertensive drug, salt of an alkaline earth metal. What drug was injected? In this case, again, we are talking about magnesium sulfate. Thank you for the attention.